Hey, Kristen, I was just getting ready to contact you to ask you how I was allowed to speak. Thank you.
Of course, I just need to promote you to a panelist when you join. So I'll be on the lookout for Abigail and Los
Lostilao and also Alicia is doing the intro, so she should be able to speak as well.
Okay, awesome.
Thank you so much.
Hi, everyone. Thanks for joining. We're going to get ready or get started here shortly.
Hi, Kristen.
Hi, Alicia. Good morning. Feel free to start the introduction when you're ready.
Yeah, the audience is there. I cannot see who is there.
Yes, the audience is here.
Oh, okay.
Yeah.
Okay, so I will start. Good morning, good afternoon. Can you hear me?
Yes, very well. Thank you.
Thank you very much. So thank you for considering Jhpiego Mozambique for this presentation. As in other countries, the appearance of the first case of COVID was an alarm. So the national effort in Mozambique was to respond on time in the best ways to reduce the catastrophic impact of this pandemic within the scarcity of resources. So Jhpiego joined to the Ministry of Health as a part of the technical working groups, providing the technical assistance to overcome the situation on time. In this context, Jhpiego reinforced the implementation of the infection prevention and control measures with other implemented partners, and focused also the trainings in the treatment centers that received the ventilators as part of the RISE project. But besides the training, it was needed to have information to know the level of compliance with the norms in place, to know if the trainings were following with the attitude and the practices in the health facilities. And also to know the availability of resources to make the decision to support the health facilities and the providers timely. So today, we will have our colleagues, Abigail, Carlos, and Lojdelao, to share with us what and how the use of technology support the Jhpiego effort to go ahead with the implementation of these activities. So welcome to Abigail, Lojdelao, and Carlos. Go ahead, please.
Good morning. Thank you, Alicia. Lojdelao, Carlos, I can start with oxygen dashboard. I don't know if you'd prefer to begin with IPC.
Oxygen dashboard, Abby, please.
Okay, perfect. Give me a moment to share the screen. Good morning from my end. Good afternoon, good evening, everyone. Pardon me. Okay. So this morning, I'm going to talk about our oxygen dashboard, the goals, inputs, and findings. Start my video so people can see what I look like as I talk. So how did this project begin? We began with a request for this tool from USAID Mozambique, and this request came in the beginning of the very first large wave of COVID-19 cases in Mozambique, which in our end began a little later than in many other countries. We saw our very first large wave in January of 2021. So what was the clinical problem that we were trying to address? The most critical aspects of caring for patients with moderate to severe COVID-19 pneumonia, even now, remains the provision of supplemental oxygen. And especially in that phase when there were many directed treatments, supplemental oxygen was really the key with evidence behind it. And during periods of surge, total oxygen demand can exceed the available resources, especially in low resource settings. And we were seeing around the globe that unanticipated oxygen shortages can and have had devastating consequences. This was when there were news stories out of Cairo and even out of Los Angeles of patients dying because facilities ran out of oxygen. So the conceptual goal was the creation of a shared dashboard that provides accurate real-time information on oxygen supply, demand, and projected requirements, looking at the national, provincial, and facility levels, and that can alert leadership when unexpected oxygen loss or leaks are occurring. So I kind of like to break it down to the very simple idea that we should see that the supplied oxygen that's consumed is balanced out basically by the oxygen that's used by patients. So if you imagine the tank of your car, the amount of gas in your car used up in your car should be about accounted for by how far you drive. And if you see that your tank of your car is empty, even though you haven't driven very far, that's information that's important to know because you may be leaking gas. So similarly, if we see that the supply of oxygen is being depleted really quickly when oxygen is not being used by as many patients as we'd anticipate for that depletion, then there's a problem in the system that needs to be addressed. So the oxygen dashboard architecture includes a few individuals at each facility with an associated tablet computer who are trained and designated to upload the data data fields we requested to the central provincial level managers who have access to the information. And also that information then is both held at the Ministry of Health on their platform and also visible to central level managers. And then this information, as desired or identified by the Ministry of Health, can be also shared with donors and funders and collaborators as seen appropriate. The technical aspects of the platform was developed in Java and MySQL and can integrate with DHIS and the COBO toolbox. So these are the data inputs, what goes into the oxygen dashboard. So first thing we wanted to know is information about the supply of oxygen, and that this is information gets entered daily. So we wanted to know the quantity of liquid oxygen available at 6 a.m. every day, the quantity of oxygen cylinders available at 6 a.m. every day, also the date of the last delivery of liquid oxygen and cylinders, and the date of oxygen liquid or cylinders, the quantity delivered at the last date, and then the number of concentrators currently in use. The combination of this information made it possible for us to then mathematically derive how much oxygen is utilized on a 24-hour basis. And then on the other side, on the utilization side, we wanted the following data about patients, which is also entered daily. The total number of patients admitted to the facility, the number receiving no oxygen therapy, the number receiving oxygen only by simple nasal cannula, and then the number receiving oxygen, you can see here, by different levels of oxygen therapy. And the reason we chose each of these categories and to count patients in this way, as you'll see in a moment, is because each of these oxygen supplementation technologies has a estimatable typical level of oxygen liters per minute that are used. So you can see how one of our data entry screens appears to the data entry person at each facility. You can see that they put in their health unit, and then for each of the patient categories, we've included a picture both within the data entry screen, and then this has all gone into more detail when we do the training and follow-up. But this is our way to make sure that the person entering the information, even if they are not a clinician, knows exactly what kind of oxygen therapy we're asking about. And then again, like I said, we wanted to take the knowledge of how many patients in each category and convert that into how much oxygen per day are patients consuming. So those of us who work at the bedside, I'm one of those folks, what we're used to dialing in is liters per minute. That's how we think about nasal cannula or even a high flow nasal cannula. What we want to know, if we're talking about oxygen supply, is how many liters in a day. So that is pretty easy math. We know there are 1,440 minutes in every day. And that will get us to the oxygen liters per day. And then to know per category patients, all the patients using nasal cannula oxygen, you're going to take that estimate per day and multiply that by the number of patients counted using that modality. How do we get these assumptions into the model? We first used the information from the UCSF STAR online oxygen calculator for these internationally verified estimates. We then performed an internal audit in which we compared the estimates to the actual oxygen flow rates used for patients in the health facilities here, and found that there's a very high agreement between our estimates and actual practice. And there were a few categories where actual practice varied slightly from the estimates, and so we adjusted our model to base our estimates on Mozambican practices as opposed to the international estimates that we'd been previously provided. And so how did we actually go about implementing the dashboard? So number one is the data collection process. We were lucky. We built this upon an already existing network of sites that are using, they've been working with Jhpiego Mozambique to collect data for other systems, such as a equipment monitor platform and the IPC dashboard, which you'll hear about in a moment. And so we already had a network and collaborators on each site. And also those collaborators were already using tablet computers that we had provided. And so they were very familiar with how they worked and utilizing those tablets for data entry. And then again, we already had designated staff that we collaborated with closely in data collection for other processes, and where we had pre-existing relationships. The training began with an initial PowerPoint training with accompanying printed orientation to the dashboard purpose, and then the data entry process with a specific section for each and every data field. We also developed and distributed job aids for use by the on-site team, including a printed data entry sheet, which could be kept as a hard copy. And then the initial training was followed by regular one-on-one, but first by one-on-one practice data entry to identify areas of confusion or difficulty, and then regular check-ins with one-on-one review of the data and how it had been filled in. And then the validation process included external data validation with regular data review meetings with each site team. And then the launch and dissemination began with one site as a pilot and expanded to all the CCOVs within Mozambique. The CCOVs is the term used for the COVID treatment centers. So that was the input side of the dashboard. To switch to what data the dashboard actually puts out, it was developed to provide the following graphical outputs: information about facility patient census by oxygen therapy modality, so dividing how many patients are admitted by what kinds of oxygen they're using, converting that information into the volume of oxygen consumed by patients over 24 hours, also divided by oxygen therapy modality, the volume by which the oxygen reserves have been depleted over 24 hours, so looking at the tanks of liquid oxygen or supply of cylinders, and then unexplained oxygen losses within the per 24-hour period. I want to show you how that looks now. So this is the simplest graph that the system provides. This shows you, the brown line shows by date the number of patients admitted to a facility. So that's the brown line. And then subdividing that brown line total, we have each of the different types of oxygen therapy modality that a patient might be using in that facility. So you can see in this facility, there were no intubated patients during the period we're looking at. There were many patients using a face mask non-rebreather. And then about roughly equivalent numbers of patients who were receiving simple nasal cannula or receiving non-invasive ventilation. And now this graph, which looks very similar, converts the number of patients at each oxygen therapy modality now to the volume of their oxygen that we estimate they're consuming. And this is in cubic meters as a volume. And so you can see while the lines in the total especially follow a roughly similar trajectory, you can see, for example, the patients using simple nasal cannula, due to the low oxygen flow rate, account for a very small proportion of the oxygen consumed at this facility, whereas the patients receiving face mask and non-rebreather and non-invasive ventilation, though they were relatively fewer patients, are accounting for more of the oxygen consumption, which stands to reason is what we'd expect. You can also just note it with this graph over the time period that we were looking at the tail end of one of the COVID waves in Mozambique. And you can see here that as you'd expect, the number of patients and amount of oxygen consumed trends towards zero. This graph is slightly more complicated, but really one of the important things that we were able to obtain from the oxygen dashboard. So the blue line here is the same line as the brown line in the prior graph. How many cubic meters of oxygen are used by our estimates by all the patients in the facility. So carrying that over to this blue line, what the orange line gives us is the amount of oxygen depleted from the tank. So on the daily measurements of the liquid oxygen tank, how many cubic meters were utilized from that tank every 24-hour period measured. And what you can see that's high relevance to us is that there's obviously a large difference between these numbers. So the oxygen that was depleted from the tank every 24 hours was about 3,000 or 2,000 to 3,000 cubic meters of oxygen, liquid oxygen per day, whereas the amount of oxygen consumed by patients was in the range of 500 to 1,000. So that big, large difference we actually then converted into cost estimates. And this is in Mozambican Medicais. And you can see that the orange line, which is the volume of oxygen depleted that isn't accounted for by our estimates of patient usage, amounts to hundreds of thousands of Medicais, which is in the tens of thousands of dollars range. And you can see as also something is also possibly expected, as the number of patients and the amount of oxygen used by patients declined, so did the leak that we estimated. So we can tell that the leaks that were present in the facility were really correlated with overall flow and overall demand. And we even returned during a period of time when there were no patients at all admitted, and identified that there was still an ongoing leak that clearly in this case could not be accounted for by patient demand because there were no patients present. And this was just an estimate of the cost of the leak when there were no patients admitted. And then with that information, we engaged the clinical team at the facility where we found this significant leak, and did an audit of the entire facility and found several sites and possible sources of oxygen leak in collaboration with the site engineer. This picture to your right shows the gas flow regulator, and we noted that even when fully turned off, many of these regulators still had a significant flow leak. And so that was among the portfolio of information we fed back to the site directors to support them in addressing the sources of oxygen leak. And then we also have continued to be in close discussion with the clinical directors of the health facilities and district health departments. And the feedback we've gotten is that having the site level data about the patient oxygen needs and the disease severity, so knowing which facilities are full of patients and how sick the patients are, which is information you can assume based on our patient data, has been very useful to those clinical directors in planning and addressing the COVID waves that have continued to come since the first one. So in terms of sustainability of this tool, the data tool is built on a platform hosted by the Ministry of Health, and the plan at the end of the project is for a transition period in order to train Ministry of Health personnel to manage and maintain the full data platform. And that's it. I don't know if my colleagues want to say if they want to take questions now for the oxygen dashboard, or should we hold all questions to the end?
Thanks, Abigail. There are a couple of quick questions in the chat that may be helpful to take right now before we move on.
Let me hop over there.
The first is about slide 16 and regarding the graphs there, whether those numbers are representative of numbers of patients.
Sorry, let me hop back over there. Right, so just taking this slide in a little more detail than I was able to. So if you're looking at the first date on the graph time period, this moment there were 56 patients in total using oxygen therapy at this hospital. Of those, that 56 total was made up of 32 patients who were getting oxygen by a face mask non-rebreather. 13 were getting a simple nasal cannula, and 11 were on a non-invasive ventilation CPAP device. Does that make a little more sense? Does that answer the question?
I think that's clear. Thank you. The next question in the chat is, what is the cause of the loss? And I believe this is regarding loss of oxygen that you went on to discuss regarding leaks. Perhaps you could say a little bit more of that.
That answer is going to be a little bit different for every facility. I guess it's worth saying this is one of the challenges, of course, of addressing how the pandemic was addressed, that many of these facilities were built. Mozambique used an approach where dedicated COVID facilities were built at the beginning of the pandemic with the intention of the patients who were diagnosed with COVID would be treated in these dedicated facilities, but that also meant rapid building of health facilities with capacity to treat hypoxic patients. So I think, and as I understand it, different donors and different collaborators built different facilities. And so one of the challenges has been that different sources of leak have occurred and been identified at different facilities based on how they were built and whether it was a reappropriated facility that had previously provided oxygen or one that was built very rapidly at the beginning of the pandemic. But we've been finding that the leak rates have been really significant, in fact, accounting for more oxygen than that we can explain by patient use. But many of the times it's in the actual, the system, of course, that connects, especially when there are tanks, the system that connects the tank to the eventual patient at the other end involves a lot of sources of possible mechanical failure and therefore leak.
Thanks, Abigail.
I know Jalal and Cristobal could go into more detail on that process of evaluating for sources of leak, but I don't know how deep a level of detail we should go into right this moment.
Thanks, Abigail. The next question is regarding dissemination of the dashboard. How has this been disseminated and any challenges experienced? And if challenges, how have we overcome those challenges?
So they have been disseminated to all of the COVID. It has been disseminated to all the COVID treatment centers. The main challenges we've had, they're often the individuals tasked with filling in the data are not at all the facilities bedside clinicians, and so we've had to sometimes go back and clarify some of the terms, especially the more this is not an issue at all of the facilities because not all of the facilities have non-invasive ventilation or high flow nasal cannula, but making sure that people understand the differences between those kinds of semantics when they're not the clinicians at the bedside setting up and administering oxygen, that is required returns and more further discussion and further clarifications and making sure we understood how to term the questions in the data fields that there was assisting the individuals on the ground in collecting the data we wanted.
Thanks. There are a couple of other questions and then some questions about leakage that we can take, register and follow up by email. We'll just take these two more from the chat. The next one, Abigail, is how close was the oxygen consumption calculation based on patient data registration versus the real oxygen consumption registered?
So we've got, I'm going to kind of, the true thing that would be very hard to really measure is to somehow measure the flow at each patient's bed in total and add that up. I think that would be possible in if you're talking about the nasal cannula patients and the face mask patients, but especially when you get to patients who are on CPAP and patients, there's a lot of possible leak in that system, and we don't program by liters per minute. So I think at some point, and I'm not an oxygen and medical gas engineer, although we did work with a medical gas engineer in this design and follow up. I think we're ultimately always going to be making an estimate in terms of how much is the absolute amount of gas that the patients are using. So that was an estimate, and it was an estimate made to the best of our ability with the understanding that there would be some confidence interval around our calculations. But the number that we were able to be really confident that we are measuring is how much gas was depleted from, especially this site, which was one of the largest sites, had a liquid oxygen tank. So you can get a pretty hard and clear number on the amount of oxygen being depleted from the tank every day, because that's identified by meter readings. So unless the meter is miscalibrated, at least you've got a very hard and clear number. And so even I think it's important to kind of take into account that the blue line, the patient use estimates, may be an error. But I think what's important to notice is even if we are off by 50%, even if the true value of oxygen consumption is twice what we estimated, which I think is unlikely, then we are still really seeing a very large distance between the amount of oxygen utilized from the tanks and for the liquid oxygen tank and the amount utilized by patients. I don't know if that's a little more clear. I think, again, not being a medical gas expert, from what we understood and the people we worked with and the reading we've done, having an exact number of how much oxygen all the patients are using is going to be hard. What's important is to identify if there is what the degree of leak and difference there is, and how much you can reduce that.
Thanks so much. Let's take one more quick question on this and then move on to the IPC dashboard. The next question is also, did you think about using control charts to predict deviations in the dashboard?
I'm sorry, I'm not sure what a control chart is. I don't know if Anunaya Jane can unmute to give me more information. Maybe we should think about using those. Or Amy, I don't know if you
Perhaps we should I think we're halfway through, Abigail. Let's take these questions and document them, and then we can send a Q&A to the group written. I think that would be helpful so we can further those conversations offline. Thank you.
Okay, I'm going to go ahead and stop my share and mute on my end then.
Thanks, Abigail. Los Talao, you should be able to share your screen.
Thank you, Amy.
Thank you.
I'm starting to share the screen right now. And one other thing that I'll to say is that this will be a combined presentation with Carlos. So Carlos is able to unmute. He is with Alicia's computer. So Carlos, we can go ahead. Me? Are you able to hear me?
I think we need to enable Adriana to speak. Kristen, if you can do that, please.
I just did.
Thank you.
Hi, good afternoon, good morning. Can you hear me?
Yes, we can hear you.
Hi. Can you hear me?
Yes, very well, Carlos. Please go ahead.
Thank you. So I will continue with the presentation. I'm presenting now the impact of the IPC dashboard. Next slide, please. I can't see the presentation. Yes, Lozilla, next slide. Okay, thank you. Well, just to begin is to say that in the beginning of COVID-19 pandemic in Mozambique, the MOH was concerned with the protection of health providers and also how central level managers could have detailed information on IPC readiness and the performance. This was related to public health facilities. And with that in mind, the MOH established IPC as a priority area for support. And we had problems. So MOH was facing problems related to IPC performance assessment, which we are only carried out quarterly. And also we had the MOH receiving the performance data with delays. And there was consequently minimal control of logistics of PPE, and we had frequent national stockouts. Next slide. Well, to solve the problems that I mentioned before and ensure that the health professionals are protected, the MOH decided to implement a mechanism to monitor IPC at health facilities and also to have the IPC data timely so that the decision making would be quick and ensure that the IPC protocols ensure that the health providers have compliance of IPC protocols at health facilities. Next slide. So the mechanism in this presentation is the IPC dashboard. So the goal of the mechanism was to develop and implement preventive measures through a platform. So the IPC dashboard to support the management of IPC program, providing a needs to report approach, and also to have immediate intervention in case it was needed. Next slide. So the IPC tool, the IPC dashboard can be used online or offline so that the health providers can perform data entry. As you can see there, it was developed in the first quarter of 2020 and is being used since then until now. Currently, we have more than 250 users from all provinces of Mozambique, which we are trained to use the IPC tool, and they can have access to use it. Next slide, please. So here we have the steps we have gone through for the implementation of the IPC dashboard. In the first step, we had the identification of IPC problem, which I have talked before. And we have defined the two requirements. And then we supported the MOH to prepare a COVID-19 checklist. And this checklist was approved by the MOH in step 2. So we have the proposal solution to MOH at the Ministry of Health. Then we had the approval of the COVID-19 checklist instrument by the MOH. Then in step 2, we had also the selection of development tools, which was Java web application, and also the approval of this development by the MOH. Just to say that the development of the IPC tool has been done in coordination with the MOH and all relevant stakeholders in Mozambique. In step 3, we had the development of a digital solution, the IPC tool, and piloting of this IPC tool into health facilities, where we had the COVID treatment in Mavalane Hospital and also in Polana-Kanis Hospital. Then we had the report of the pilot, and then we had the approval of the implementation phase by the MOH. So for the step 4, we had the training of staff, both from the MOH and also from the provincial implementing partners. And then we had the full rollout of the IPC tool. Well, the technical aspects, Los Delau can talk this more when he intervenes. So it was developed in Java, MySQL, but it can be integrated with other platforms, for example, the Copo Toolbox and the HGIS Doge. So as you can see there, this is the IPC tool architecture, how the data workflow. In the bottom, you can see the healthy facilities where data entry happens. And currently we have 164 healthy facilities using the IPC tool. And when we move up at the middle part of the tool, we have the provincial health directorates or provincial health services, with the managers having access of the individual health facility information for decision making. Then we have the higher level, which is the central level at the MOH, which is possible to have the information from all health facilities of the country. Well, the IPC tool is being implemented in 2 types of health facilities. We have the COVID-19 treatment centers, or the COVID-19 inpatient centers, and also we have the COVID-19 transit centers. The latter are healthy facilities which support the COVID-19 treatment centers. They support with triage and other activities so that we don't have a lot of work in COVID-19 treatment centers. So these are the transit centers. Well, the IPC tool, as you can see here, is present in Mozambique in all provinces, according to MOH guidance. Some provinces use it more than other provinces. For example, in Zambezia, you can have there with 25 healthy facilities using the IPC tool. And this is related because in the beginning, when we introduced the IPC tool, we are using it in Ajuda sites in the beginning of the implementation, but now we are scaling up for other health facilities. And in Zambezia, we have many Ajuda sites. So we have differences of IPC implementation across the provinces according to the needs and according to the guidance by the Minister of Health. Well, here you can see the data which the data enters in the IPC tool, and we have there different types of information being collected by the IPC tool. The first one is the daily assessment checklist. This daily assessment has 12 areas, and it is more related to daily and correct use of IPC procedures by the health providers working at different spaces of the health facilities. And from here, we can, for example, have access of lack of follow-up of IPC procedures, which may be related to lack of materials, for example, or to lack of equipment, or not knowing how to do it. For example, when the health providers, we are not trained to use it, and or maybe even because of negligence, when the health providers have materials, equipment, they know how to use it, but by negligence, they don't use it. So the data assessment checklist is possible to have this information. Then we have the weekly assessment checklist. This weekly assessment checklist has 11 areas, and we use it to verify the management, administrative, and the environment measures. For example, IPC related training, tracking at health facility level, the PPE monitoring, or the waste management at the health facility level, and even the availability of human resources. Then we have the monthly assessment, which we developed from the, the monthly assessment we developed from the weekly assessment. And what we have done was to develop a standard using the weekly assessment, and it is possible to rate the health facilities according to the performance. Well, I think I don't see again here the presentation. Close the lab. Well, maybe I can continue talking. Okay, thank you, Losdilao. So here we have the data coming out from the IPC tool. So it is possible from the IPC tool to follow up the active and no-active healthy facilities, the performance of individual health facilities on IPC, and to have the performance gaps which are needed to have the action plans by the health managers. And also it's possible to see the facility PPE stocks, so that is possible to follow up and avoid stock outs. And from the IPC tool, it's possible also to have notification of assessment results by email for all levels, at the health facility level, at the district, province, and also at central level. It is possible to have the notification of the assessment results by email. I will let Losdilao to continue with the presentation. Thank you.
Thank you, Carlos. Well, Carlos is jumping out now because he thinks that this is kind of technical part, but it isn't. So I'm going through now. So this is the front end of the application. It comes out like this, and this is the login part, because to access the tool, the person should have any credential given. And these credentials are given by the MOH. So the health facility on the province level ask for credentials here in the MOH on the central level. So once the MOH approve this credential here, once the MOH accept that we credential the person, we credential, and then the application sends the email with the information of login. And this is another input screen, and this one is the first one that it's collected. Here we collect important information like the assessment tool that it's going to be filled, the health facility, the date of the assessment that it's going to be done, and also the period of time that the assessment it's going to be done. Because here we'd like to understand if the check or the assessment it's being done in the morning or in the afternoon or in the end of the day. It was something that it matters a lot to us to understand about the assessment. And this, it is the menu of areas that it's filled on each assessment. This one, for example, it is for the daily assessment. The areas comes like this on image styles with a test on the button. This was designed like this to be a good look and feel for the users. What we thought it should be very friendly and easier to use. So we decided to design an approach of image-based so that it can be easier to use. So once the person hit on each area of in an area, the system will prompt a next screen, which is like this. It comes the assessment questions, and it comes with option that the user can mark if it is yes or no. And sometimes it brings also another options to select. And once it's done like this, we also design it like this so that it can be very, very easier. Here the person has just to fill yes and no. And if there is another considerations that he should give, he can give here in terms of numbers or another very concrete thing that you would like to write. And here we bring some of the reports that the system print. So we have a report of the detailed assessment. So when the clinical part do the assessment, the different levels of the health facility, province level, and the MOH can access this report detailedly and see what was filled for each questions of assessment. He can see which was the option chosen, and also can see the comment of the person for each question option. So for example, in this one, we can see that for this question assessment, the person chose no, and here gave us an comment. So this is the level that things can be saw here on the detailed report of the assessments. This is another report that shows the implementation score. This is the report that is very used by the province and the MOH. The province and the MOH use this report to see the score of the areas that are being assessed, that are being made the assessment. So this report will show how much was spent to point, how much they succeeded to score, and how much they didn't succeed, and it also brings us here the total of score. And this is the information that they use to strategically decide what are they going to do in terms of interventions through the areas. So if they see that one area it's very down, they can do a concrete intervention to potentially to potentially score up this area. And one of the things that they do sometimes is that to decide to, instead of moving effort for one area, they move efforts for other areas in terms of distributions of, for example, human resources. So this is another report. This is the change management. One thing that maybe I didn't mention before is that when the assessment is done, the person automatically will be prompted questions to also give and change management plan for range assessment questions that are not being responded positively. For example, if there is any criteria that is missing, the person automatically is prompted questions to implement a change management. So what is asking is what is the solution, who is going to be responsible to follow up, and what is the time, or what is the time to implement this solution. So then the MOH access this report and then follow up with them if they succeeded or no to implement the change management. And if they don't succeed, the MOH give recommendations or concrete help in each that they didn't succeed. This is another report that is very used by the provincial level. These reports bring us an idea of how the PPE are used. For example, you can see here, for this one, it is about the N95 respirator that shows that in the first day and the second was all good, but the day was already red. That means that it was stock out. There was no stock of 1995 respirator. So what they do in these cases, they just see on on other health facility or in the warehouse of the the province, if there is a stock of N95 respirator, so that they can redirect immediately to this health facility to see if they can solve the problem. So then we have a lot of dashboards, and this is one of the views that we bring here in terms of dashboards. Here we have got different filters that are, for example, provinces, district, and you can filter here what you would like to understand in terms of IPC and see in a graphical mode. So here, for example, it is brought an overview of the province score and the area score. So looking at this, the central level, you can see which are the provinces that are very low in terms of score, and you can see also which are the areas that are very low or are in good performance in terms of score, so that they can intervene, so that they can make an interventions to improve. And we also have a GIS module that is very used in the central level also, and this was projected to be used on a big screen so that they can sit and discuss the issues of the health facility implementing IPC checklist. So clicking on the point, each point, it means one health facility. So if it is red, it means that there are PPE here running out stock. So if you hit on the point, the system prompt and pop up showing the criteria that are not matching well. And also you can have here on this side the information all to read. And this is a map that can be scrolled through the areas you need to analyze. What is gained using this IPC? Here, the action plan was very carried out faster and more accurately, and with the monitoring for all levels. Because here what happened is that the MOH didn't have access immediately to these change management plans, but with the platform, they already have access, and they can intervene, and they can make interventions immediately. There is a real-time monitoring of PPA and protocols and other stuff relating to IPC. There is a fast track specific interventions at the facilities with critical IPC needs, indications of active or non-active health facilities, and emails notifications of IPC performance. So these emails are very, very used because managers, for example, don't have a lot of time to be consulting to the system. Once they receive the email, they see the information, and they many times take actions, or consulting the province level, or sometimes discussing for making a direct intervention. And thank you. This is all by our side.
Many thanks, Los Dalao and Carlos. There was one question in the chat quickly before we wrap up regarding a confirmation of who enters the data and who pays the salaries of those who enter the data.
Thank you. For why here, as I show on the architecture, the ones who enters the data are the clinical part of the health facility who are responsible of IPC. So we have a focal point of IPC in all health facility in Mozambique. So this focal point is responsible to enter the information. So the salary are not are not paid for any partner, are paid for by the MOH itself.
Just to reinforce that the structure is under the Ministry of Health focal points. So they are covered by the Ministry of Health as part of the system. Thank you.
Many thanks all. I know we're at the end of our hour. We will document the questions and share to this group with the recording, the slides, and a document with the questions and answers. So sorry, we're running out of time. Thanks all for joining, and really wonderful job. Thank you so much for sharing these innovations. This is really great to see. I know we've all been eagerly awaiting. Thank you so much, all. Take care. Have a good day.
Thank you so much.
Thank you.